this is definitely the way to go for this case. Let's see. Oh, here we go. Yeah. Great. Okay, these are my disclosures. So first of all, in a debate format, right, this is not an argument. We need to have the ability to convince folks of what we're going to proffer as the treatment for this patient. So the only way I'm going to win this debate, there's only one way, and that is by convincing you of a reductionist approach. What do I mean by that, a reductionist approach? What I mean is that surgery, and we're all surgeons here, is not a natural process. Doing less harms the patient less. Spending less time doing the surgery is a good thing. You can always do more, and do as little as possible to prevent future interventions from being impossible. Okay, so these are some very key tenets that I like to issue in my own practice. And why do I do that? Because I look at what's on the internet. I talk to my patients. Patients are terrified of spine surgery. There's nothing more terrifying to them than spine surgery. There's no surgery more terrifying, and if you Google, you'll see this. So we started on this journey of building the Awake endoscopic ERAS surgery, combining these 6 components, including using endoscope, expandable cages, and without using general anesthesia. And this shows, and I love to show this video, it's the first case I ever did. This is the former dean of FAU Business School. You can see I'm talking to him, so it's not like a rat lab, right? These are people that actually matter. And so I'm going to do this surgery, and I'm going to do this in a way that is going to be a fusion with cage, bilateral screws, and all of that, using all of these various technologies, and without intubating him, with deep sedation, but not general anesthesia. You can see the exiting nerve root being protected there. This is a standard sort of endoscopic approach, but then we're going to go on to remove the entirety of the disc and do a fusion with bilateral pedicle screws, et cetera, right? So it's a very efficient type of surgery, and when you get into this type of operation, you start to understand you can do a lot of things with it, right? So when I'm doing this surgery, what am I actually doing? What am I actually reducing, right? I said I have a reductionist approach. I'm reducing the anesthetic impact. I'm reducing operative time. I'm reducing blood loss, right? If we lose more than a shot glass of blood, it's too much. We're not cutting any muscle. We're not destroying any soft tissue. And our chance of a CSF leak, epidural hematoma, infection, et cetera, is under 1%, right? That is really amazing when you think about all the things that you worry about when you go to the operating room every day. And this is an example. This is a dentist who's having surgery. She's going to give me the thumbs up. She's ready to do the surgery. And these surgeries can be done in an incredibly efficient way. We're working through a quarter that's under 6 millimeters. So I don't care if you do tubular MIS. That's probably a 22 tube. This is a 6 millimeter tube that we're working through. So truly, truly, truly minimal in its nature and in its impact to the patient, right? So if you look at the effects, this is an example of a patient. This is an hour after surgery walking around the recovery room, right? And this is not the experience I'm used to. I'm not used to people having an MIS TLIF and walking around in a recovery room like this. And we do this because we have all this technology available, most importantly, Exparel to help with the local anesthetic effects. And this has been published. I don't need to go and recite all of the literature on what we've been doing. But we've done over 400 cases. And what is the perfect case? People go, well, Mike, I want to learn how to do this. The perfect case is a L45 spondylolisthesis, right? That's exactly the right case. Because in that type of case, you can get indirect decompression, as you see here, with a Wake TLIF. You see the ligament there buckled and then reduced by the stretching, and eventually you see complete resolution of the stenosis. And again, as you can see, we're doing minimal levels, just the level that's most symptomatic for the patient. And then do we meet the surgical goal? So this montage just kind of shows you what it looks like when you're dealing with a degenerative spondylolisthesis L45. Yes, are we getting height restoration? Of course. We're getting indirect decompression. We're getting slip correction. We're getting lordosis restoration. So all of those primary tenets of the surgery can be done in a surgery in under 1 hour with essentially minimal blood loss and no general anesthetic. Is it perfect? No. You got to face what are the issues. The biggest thing and the only thing really at risk is the dorsal root ganglion, right? So dorsal root ganglion, you have to be sensitive to it. If you're going to work through Camden's triangle, Lou and I published some papers on that. The DRG is really the structure that you need to worry about, and there really is not a lot else you need to worry about in these surgeries. So can I prove this to you? So I used to show this slide for the last 20 years. This is a slide showing the cost of surgery. This is a slide from back then. And then I started talking about bending that cost curve and getting that down, something like that, and that was theoretical in 2012. So let me show you this slide. This is a slide from John Yoon, a former fellow of ours. He's at UPenn, showing 2 curves of recovery. This is activity. This is steps taken by patients. The red is a fusion. The blue is a microdisc. So what we've done is we've taken the phenotype of recovery of a fusion and made it like going through a microdiscectomy. So that's very impactful if you think about what we're really doing. So in summary, if you're interested in the welfare of your patients, try to do less. A reductionist approach can get the goal done, get the job done over 90% of the time. You can always do more if you need to. And the real question is, what would you do if it were your spine? So thank you again, and I look forward to hearing from my friend Luis Pimenta. Thank you.